Hello, everyone. We have the pleasure today for this podcast session to have with us Teresa Maria Olasveengen from Oslo University Hospital. Thank you for having accepted our invitation in this new ISICEM initiative.
Yeah, thank you for having me. This is exciting.
It's a pleasure. It's a pleasure. So, the idea behind our conversation was to discuss a little bit the recent guidelines that came up. They wrapped up almost everything around resuscitation and cardiac arrest, dealing with cardiac arrest from the beginning till the end. So my first question to you is, what are the highlights, the changes that everybody needs to know all around the globe about it?
Yeah. So as you say, I think they are very comprehensive, everything from the system level to the epidemiology, to the basic, to the advanced, to the ICU, to the ethics. And I'm leaving out a lot of chapters, adults and children. And so I think, there's obviously, I think they tailor to a very large group. I think that's what makes them special. They tailor not only to sort of healthcare professionals, but also a lot of sort of CPR trainers and patients and their families. And so I think they're very broad guidelines. I think for me, the things that I'm most happy with that we now changed, I'm very happy to see ventilation has come back stronger in the guidelines. I think we've had these decades with a lot of focus on chest compressions. To the extent where do we really need the ventilations, and they're only in the way for the compressions. Whereas now I think there's some more guidance on. Well, I think there's some more emphasis on the importance of ventilation and effective ventilation, meaning you actually need to assess whether you're getting the air where it's supposed to go. And there's some sort of practical advice towards also using a ventilator for CPR, which is new, which I think is becoming increasingly common.
It's becoming increasingly common, and I'm also very happy about it because it's, to me, I'm not a pre-hospital physician, so it gives a little bit more of clarity where I should focus. It's not just putting the ventilator on and just run whichever modes you're accustomed to, but there's also some guidance on which parameters you should be aware of. I extremely liked the suggestions about the peak pressure level, like do the right setting. They're not very complicated, can be pre-made in your ventilator most of the time. And what about the use of ventilation strategies and tidal CO2 versus CO2 max versus CO2 trends? What are your feelings about those?
You're thinking about end-tidal CO2? Yeah. No, I think that's another really exciting sort of venue to pursue. There's not a lot in, well, obviously, I think we use end-tidal CO2 to see, if trends are increasing, we're happy with our CPR performance, we're happy with what we're doing. If we see a sharp increase, then we start thinking, do we have ROSC? But, I think we're starting to realize there's a lot more in that signal. That's not sort of guidelines ready in terms of, can we actually use it to see whether the airway is open or closed? And, can we actually use it to see, maybe we should apply just a little bit of PEEP or something like that?
Yeah, that's why I'm talking about, because it's probably getting in the way of the setting of your ventilatory parameters. Maybe one day will be, but so far it's nothing we should look into it today.
Well, I think it's nothing that you can write simply into a guideline. I think as if you're working in the setting where you have a lot of resources, you have monitoring, you have a good understanding of physiology. It's allowed to think. You're allowed to look at the capnography and say, I'm not really happy with not seeing any oscillations from my chest compressions. What can I do differently? Could I perhaps be ventilating a little bit too carefully? Do I need a little bit more volume? Or like the guidelines do open like to slight adjustment from 0 to 5 of PEEP. And then, of course, we're all very worried. Yeah.
That is a very new concept, but the preliminary data I've seen around that goes in that direction. That seems really a promising parameters that we could actually implement in the future. And so the biggest stake for the pre-hospital care would be the introduction of ventilations. And I don't know if we should go specifically on the numbers, but they are particularly well outlined in the guidelines. So I think that's as an invitation to everybody to go and read it and maybe implement it in their...
Yeah, I think though I can sort of say there's not a lot of changes in terms of ventilation rate and ventilation volume, but that's another thing. Like maybe those will change for 2030. I don't know. I think we're questioning some of our sort of dogmas of this sort of very fear of hyperventilation, where we've been very afraid of ventilating too quickly or with too large volumes. And there is a possibility that we've actually sort of fallen into the other side of maybe ventilating a little bit too carefully. Okay. So I think more and more observational data indicating that maybe it's not as detrimental as we thought, with a little bit higher than 10 and maybe a little bit more than just exactly visible chest rise. But then I think it's really hard to change the guidelines on observational data.
Yeah, that is true. I can only imagine the huge amount of work that was put behind to reach the simplest but the strongest recommendations possible. For what concerns the post-ROSC, there are always these debates about the thresholds that most of the time intensivists should aim for in terms of mean arterial pressure. There's this holy grail of 65, constantly challenged, but still stays
still there.
And then the temperature control, those two big things we have to deal with, and there's always study going on. What's the current practice recommendation?
Yeah, so again, in terms of the mean arterial pressure, I mean, nothing's really changed. There's more trial evidence. But I think we're sort of left with the believers and the non-believers. So there, I mean, I think there's pretty wide consensus that you should probably keep a map of at least 65, and then it's a bit of an open question whether there are patients where you might want to go a little higher. And then luckily we do have sort of ongoing trials, and I think with the step care trial that's also looking at different map levels. Is going to be important.
But from my point of view, it's always been, of course, you have to reduce to a number, and then mean arterial pressure seems to be one of the most important ones, but it's not the only numbers we're given. There's diastolic pressures, systolic pressures, they all mean something, but ultimately we would like to have optimal perfusion, which is the difficult thing to assess, and sometimes it's uncoupled with mean arterial pressure. So a question a little bit impossible to answer, but should we keep doing studies with too fixed level of mean arterial pressure, or shall we somewhat pause it until we find a way to assess whether the coupling between pressure and perfusion, because ultimately that's what we are probably most interested in.
Yeah, so I think what you're getting at is the sort of the fear of us throwing babies out with the bathwater and testing interventions that could be very important to certain groups, but just testing them in the wrong way, and we're sort of crossing them off the list. So I think that's a real concern to me as well, that maybe should we sort of just continue doing all these trials as we're doing now before we sort of have the knowledge we need to select our patients better? I think that's a really tough question, because on the other hand, we always seem to learn something from these trials, and maybe in a way it's good to kind of establish some sort of bare minimum, or like a baseline type threshold treatment. Yeah. But I share your concern. I am afraid that if we sort of just continue crossing, sort of de-implementing all sorts of things that are not going to be effective for everyone, then we might not be moving the field.
Which brings us to the next, the cooling, which is not so different, if you
No.
wish, choosing between few temperatures or certain duration, but which patients would actually benefit. And the step care trial will try to give an answer in the sense that maybe some patient did not have to be included because they could wake up no matter what we do, and then we could not expect any effect of cooling. What is your take about
Yeah,
that?
no, I think that's exactly the same. It's you have the believers and the non-believers, yeah, and the risk of doing a trial, sort of on the wrong patients, and then not really throwing the baby out with the bathwater. I don't know. To me, I think obviously the temperature part of step care, looking at should you use a device or not, like how aggressively should we be treating the fever, is of course it's important, and maybe as a resource thing foremost, perhaps. Like, do we need to buy these machines? Do we need to sort of train all our nurses and doctors to do this, or no, to be able to cool externally? We might argue we might need to know how to do that anyway. But I think like the question of should hypothermia, like, are we like finished with that topic? Have we completely thrown it out? And to me, I think I'm really, really curious to see with the Princess 2 trials, like the
Yeah.
early cooling. To me, like
Ultra fast,
ultra fast,
ultra early.
pre-hospital, super quick cooling. Like if that doesn't work, if there's no signal there, then I'm going to start losing faith.
Yeah, there's few ideas out there that have been tested indeed, maybe to try to go back to the data that came from the lab that seemed so encouraging. Hard to believe we could not find in real life what has been described early and that's been not found in the TTM trials. So we'll see. We're waiting for those results to be out. I think the study right now is somewhere midway. We'll see. Let's hope about it. Talking about post-ROSC leaves me with two more topics I would like to discuss with you. One is the huge chapter of neuroprognostication with our patients that survives but remain comatose. And the second one would be the actual post-intensive care with the patients that actually survives, wake up, and that has been implemented in the guidelines with more strength, and now there is all this follow-up. So let's start from neuroprognostication. Is there something new we should be aware?
Yeah, I think what I really like, the change I really like in the current guidelines is that it doesn't only sort of offer the pathway of look for these things to look for bad outcome, that there's actually specific things we could be looking at to say this, my patient has a reactive EEG pattern. That's actually a really positive prognostic sign. That means I should really think twice before I withdraw treatment. So I sort of like that concept that we're not only looking for the people that are going to die anyway, but we're also sort of trying to identify the ones that we definitely need to give time.
Yeah, that's very, very interesting. So that today is no more just we are capable to tell you which patients will never wake up, but maybe we can integrate new variables, new elements, new tests, such as the EEG, into our discussions with the family, with the other colleagues. To be, it's going to be a gray zone, but we can be a bit more confident about putting those patients in the gray zone and no more outside to will never wake up or well.
Yeah, and I think we should be honest and maybe a little bit more brave when speaking to the family. I think they should get to know what we know and what we don't know, obviously. But no, I think though what I sort of had hoped we could be more clear on in the guidelines. I was like trying to make this point. I felt like I didn't win this battle, but I do feel like neuroprognostication is that's one issue. I think it doesn't. Because we have this algorithm in cardiac arrest where it's like, if you have this, plus one of this, plus one of this, then you can withdraw. I think sometimes we forget that even to enter into the whole neuroprognostication, we should always be questioning, is intensive care right for this patient? Like, does this patient have the sort of the resources in themselves to sort of withhold our ICU treatment? Because it's invasive, it's painful, it's a lot of stuff that, to survive. And sometimes I worry that because we have these strict guidelines that we forget the basics. Like, is this actually a patient that would have wanted and is in a condition to take advantage of intensive care?
And then now putting a lot of attention of survivorships and follow-up maybe can also somewhat comes back to the other chapters, maybe to brings a little bit more of awareness and attention on the patients itself, on actually the quality of life, on all these things that sometimes have been neglected in the past, I think, because of course we tend to treat some cases as cases and forget about the human environment that is around. What do you think? Did the guidelines implement this chapter enough, or there's still room to grow?
Yeah, I think that's definitely been a big sort of growth the last couple of cycles. I think it's come in a lot stronger. I'm really happy that the guidelines specifically say that we should be assessing the patients before they leave us, so that we know whether they need follow-up or not. And I think the guidelines give us some tools. I know that it's things we're discussing in Norway for our sort of national registries and quality work. Like, does this actually help us make some sort of specific indicators where we can measure ourselves and make sure that we're actually assessing and then providing the follow-up that they need? So I think that's been good.
But thank you very much. I forgot one question, but I'm going to come back to it.
Okay.
Do you think we need cardiac arrest centers in the future? There's a process of kind of trying to understand what a cardiac arrest centers should be. And there is a lot of controversies. Then you also have believers and non-believers. It seems to me hard to non-believe in something that has been done somewhere else and seems to improve quality. But is it applicable in Europe, everywhere in the world? What's your take there?
So my take, I guess I'm a believer in everything, it seems like. Yeah. Also a believer in cardiac arrest centers. And I think maybe not because it's so important to be admitted to a place that can offer PCI 24 hours a day. But I think it's just something with the whole complexity of the patient group, just knowing how to handle them in the ICU, just have the sort of, in terms of follow-up, in terms of prognostication, it's a really big package. And I think there is a difference in the quality of care that we're able to offer in a cardiac arrest center that does these things regularly versus a local hospital that does not.
Okay, well, thank you very much. Last but not least, what's the results you would like to see first? What's the study that you're waiting with most hope or curiosity?
Oh, okay. So hard to choose. Of course, I'm really, really curious about the Princess 2 hypothermia trial, but maybe I'd actually have to say the sedation part of the STEP care trial.
Okay.
Yeah.
We'll see.
We'll see.
Meanwhile, thank you very much. And thank you for everybody to listen to this podcast. Thank you.
Thank you.